Today, we're diving into a major study from the journal Brain Stimulation. It's a deep look led by a team at the VA and Brown University at how effective different kinds of transcranial magnetic stimulation really are for treating PTSD. You see, this research tackles a really critical question for clinicians. We know that transcranial magnetic stimulation, or TMS, is being used more and more for PTSD. But it's not a single treatment. There are actually several different protocols, each with its own parameters. So that brings us to the big question. In the real world, do all of these different approaches work just as well?
Now, to really understand why this research is so important, we have to start with the problem it's trying to solve. And that is the immense challenge of treating post-traumatic stress disorder.
PTSD can be a profoundly disabling condition. It's often tangled up with depression, substance use, and, tragically, an increased risk of suicide. And for many people, especially the military veterans who were part of this study, the treatments we have now just aren't effective enough. This creates a really urgent need for better options.
And that's exactly where TMS comes into the picture. It's already FDA cleared for major depressive disorder, which has led to its widespread off-label use for patients who are dealing with both depression and PTSD. Now, we already knew from past research that high-frequency TMS works better than a placebo for PTSD, but that left a big gap in our knowledge. So the main goal of this study was to fill that gap by figuring out if 3 common but distinct TMS protocols give you equivalent results in a real clinical setting.
So how did the researchers set this up to answer the question with real rigor? Let's break down exactly how they designed this study.
Okay, so the team took a look at real-world clinical data from 756 veterans who were treated across multiple VA medical centers. This was a big retrospective study. And a key detail here is that every single one of these patients had diagnoses for both PTSD and major depressive disorder. To make sure the comparison between the treatment groups was fair, they used a really powerful statistical tool called propensity score matching.
So what exactly is propensity score matching? Well, in an observational study like this one, you can't just randomly assign patients to a treatment group, and that can create bias. Maybe younger patients were more likely to get one protocol than another. Propensity matching helps fix that. It basically creates balanced groups by matching up patients from each protocol who have very similar baseline characteristics, things like age, gender, and how severe their symptoms were at the start. It effectively mimics the kind of balance you get in a randomized controlled trial, which lets you make a much stronger, more reliable comparison.
All right, this table lays out the 3 protocols they compared. First, you've got the standard 10 Hz protocol, which targets the left dorsolateral prefrontal cortex, or DLPFC. Second is intermittent theta burst stimulation, or ITBS. It uses a more complex pulse pattern, but check this out. It delivers way fewer pulses, only 600 compared to 3,000. And that is a huge deal because it makes the treatment session so much faster. And third is deep TMS, or DTMS, which uses a special kind of coil to stimulate deeper brain regions, like the medial prefrontal cortex.
So how did they measure success? They used the PCL-5, which is a standard scale for PTSD symptoms. They were looking for 2 main outcomes. The first is response, which means a clinically meaningful improvement, specifically a drop of more than 10 points on that scale. The second is remission, and that's a much higher bar. That means the patient's score dropped below 33, which indicates they no longer meet the symptom criteria for a PTSD diagnosis. Okay, so how did the protocols do? Let's get to the core findings, starting with how they impacted PTSD symptoms.
The first major result is crystal clear right here. This graph shows the average PTSD score week by week for each of the 3 protocols. Just look at how all 3 lines follow this substantial and remarkably parallel downward path. The bottom line is, across the board, all 3 treatments led to clinically significant reductions in symptoms, with an average drop of 18 to 22 points. That is a really powerful positive signal right from the get-go.
Now let's look at the head-to-head comparisons after the propensity matching. First up, ITBS versus the 10 Hz standard. The response rate for ITBS was almost 66%, compared to about 59% for the 10 Hz protocol. Remission rates were also very similar. So, the critical statistical takeaway here is that ITBS was found to be non-inferior to the standard protocol. In plain English, that means it's statistically confirmed to be no worse than the standard of care.
And we see pretty much the exact same pattern when we look at deep TMS. When it was compared to the 10 Hz protocol in those matched patient groups, DTMS had a response rate of 78% versus about 68% for the standard. Once again, looking at all the outcomes, the statistical analysis confirmed that DTMS was also non-inferior to 10 Hz stimulation. The evidence is just really consistent. The newer protocols perform at least as well as the standard one.
But remember, every veteran in this study also had a diagnosis of major depression. So the next question is, did this pattern of results also apply to their depressive symptoms? Let's take a look at those secondary outcomes.
And the answer is a very clear yes. This graph here shows the scores for depression symptoms over the 6 weeks of treatment. And that trajectory looks strikingly similar to what we just saw for PTSD. All 3 protocols brought on significant improvement. And most importantly, the statistical analysis again confirmed that both ITBS and DTMS were not inferior to the 10 Hz standard for depression response and remission. This consistency across both PTSD and depression is a very, very robust finding.
So, we have some really strong evidence that these treatments are comparably effective. Now let's dig into the discussion to understand the finer points of what this all means, and, just as importantly, to acknowledge the study's limitations. Okay, so this is a crucial statistical point. The study clearly demonstrated non-inferiority. This means that, statistically, the new protocols are proven to be not worse than the 10 Hz baseline. But, and this is interesting, the study could not support strict equivalence. And why is that? Well, it's because ITBS and DTMS actually showed slightly better outcomes on average. So the clinical takeaway is simple. The newer protocols work at least as well as the standard approach, and maybe even a little bit better.
Of course, every study has its limitations, and it's important to be upfront about them. First, the entire group studied was U.S. military veterans, so we'll need to see if these findings hold up in civilian populations. Second, because this was a retrospective study, there was no sham or placebo control group. Third, since every patient had both PTSD and depression, it's impossible to completely separate the treatment's effect on PTSD alone. And finally, the results were based on self-report questionnaires, not the gold standard clinician-administered interviews.
So with all those results and limitations in mind, what is the clear, actionable take-home message for clinicians and for patients?
This right here is the key implication. Because this study shows that the protocols have comparable effectiveness, the choice of which one to use doesn't have to be about which one is superior. Instead, clinicians can make the decision based on practical things. For example, ITBS sessions are way shorter, which is the huge advantage for both a patient's schedule and the clinic's workflow. Other things, like which device is available or a patient's individual tolerability, can now be the deciding factors, which ultimately helps expand access to care.
So the main conclusion from this large, real-world study is definitive. In veterans who have both PTSD and depression, the standard 10 Hz protocol, the much faster ITBS protocol, and the deeper stimulating DTMS protocol all show comparable and robust clinical effectiveness. Both theta burst and deep TMS are statistically non-inferior to the standard treatment.
And this leaves us with a really interesting question for the future. Now that we have strong evidence that these protocols are all comparably effective, the whole conversation can shift. It's no longer about which one is best, but instead, which one is right for this patient in this clinic. How are practical factors, like the massive time savings of ITBS or just patient preference, going to shape the future of how we use TMS therapy?